Hey everybody, welcome back to my channel at the Cards NP. I'm Kate Morgan and I wanted to talk to you about my latest article that was published on the American College of Cardiology website, which is acc.org, under their cardiovascular team section. And it is called the Inpatient Consult for Acute Heart Failure, the Opportunity. So I know a lot of people don't like to read, so I'm going to read it to you. All right, so this is a topic that I'm very passionate about. It's very important to take care of our heart failure patients. All right, and here it is. Hospital admission is our opportunity to influence the management and improve the lives of patients with heart failure. Clinical assessment of patients' New York Heart Association functional classification, ACC, and American Heart Association staging and echocardiographic findings guide our therapy. Being involved early in the patient's hospital stay allows us to educate and treat the patient with initial management focusing on diuresis and consideration for starting pharmacologic therapy with mortality benefits. We also need to determine etiology and explore further diagnostic workup. Multidisciplinary collaboration with hospitalists, dietitians, physical therapists is a valuable resource to treat comorbid conditions. And here I post a link to the 2019 ACC Expert Consensus Decision Pathway on Risk Assessment, Management, and Clinical Trajectory of Patients Hospitalized with Heart Failure, published on the acc.org website. This is an invaluable resource that highlights all of the considerations for navigating patients through their hospital stays and beyond. As cardiology providers, our role is to continually evaluate the patient's clinical volume status, response to medications, and consideration for guideline-directed medical therapies. As we know, there are several classes of drugs that have been shown to improve mortality or reduce hospitalizations for patients with heart failure with reduced ejection fraction. And heart failure with reduced EF is less than or equal to 40%. For example, the Paradigm HF trial, which is an acronym for Prospective Comparison of ARNI with ACE inhibitor to determine impact on global mortality and morbidity in heart failure. This trial has shown better outcomes with sacubitril/valsartan over enalapril, and it was the Pioneer HF trial, which is an acronym for comparison of sacubitril/valsartan versus enalapril on effect of NT-proBNP in patients stabilized from an acute heart failure episode. So this trial demonstrated efficacy and safety with initiation of an ARNI in the hospital setting. We must document the initiation or contraindications to prescribing the following medications with regard to mortality benefits. So our medications with mortality benefits, as we know, is the ACE inhibitor, which is the angiotensin converting enzyme inhibitor, the ARNI, which is angiotensin receptor neprilysin inhibitor, and the ARB, which is the angiotensin receptor blocker. Also, evidence-based beta blockers, of which there are 3, metoprolol succinate, bisoprolol, and carvedilol. MRA, mineralocorticoid receptor antagonist, which is either spironolactone or eplerenone, and also consideration for African American patients with isosorbide dinitrate and hydralazine combination. So those classes of medications, we really need to take a look and see if our patients qualify for these medications and make sure that if they do qualify, let's get them on it. Okay, continuing on. References such as the newly updated Treat HF app help guide medication selection and dosing for patients with heart failure and reduced ejection fraction. The CHAMP-HF registry, and that's an acronym for Change the Management of Patients with Heart Failure. This registry, published in 2018, has taught us to be more diligent with complying with the guidelines and reaching target doses of medications. The trialists found that 3,518 eligible patients in the registry, 27% were not prescribed an ACE inhibitor, an ARB, or an ARNI. 33% were not prescribed a beta blocker, and 67% were not prescribed a mineralocorticoid receptor antagonist. And of those who were prescribed the appropriate medications, 17% on ACE and ARB, 14% on ARNI, 23% on beta blockers were not at target doses. So it's really important not only to make sure we get the patient on these guideline-directed medications, but also that we continue to evaluate the patient in the clinic setting and get these patients to target doses. All right. The opportunity to improve the quality of life for patients with heart failure is a privilege we have as cardiology providers. A patient's initial hospitalization guides medical management, and our continual assessment of that patient's functional status guides future consideration of advanced therapies. So thank you guys for listening to me read my article. Again, it's very important to make sure your patients are on all these guideline-directed medications. And of course, now we know that there's a fourth pillar coming out for heart failure with reduced ejection fraction, and that is the SGLT2 inhibitors. So you will hear lots more about those classes of medications. All right, see you in the next video.